What types of settings do CRNAs practice? What kind of surgeries do they do? Is there anything that they can't do under their current scope of practice? And really the easiest, shortest answer for that is there's nothing that we can't do under our scope of practice. We really can provide surgeries for all different types of surgery, whether that's open heart, whether that's pediatrics, obstetrics, regional, so pain management. So dental clinics, ophthalmology clinics, fertility clinics, ketamine clinics. In fact, many CRNAs I know start their own pain clinics and run their own ketamine clinics. We even can do like med spas where we do a lot of different types of injections along that lines of work. So there's a lot of variation in practice, not just hospital work. There are a lot of things that you can do on the side. I'm Jenny Finnell, CRNA and founder of CRNA School Prep Academy. I have always had a passion for helping those who aspire to become a CRNA. A couple of years ago, I started mentoring a handful of prospective students. Fast forward to today, and I have a successful mentoring program that has impacted hundreds of aspiring and now current nurse anesthesia students. What I enjoy the most in my business is connecting with you, the future CRNA. I love learning and growing with you. The road to CRNA is full of unique challenges, and no two journeys are the same. But every journey has a learning opportunity. I'm here to share what I have learned over the years from not just my students, but CRNA community leaders, program faculty, and from my time as a practicing CRNA. This will be your one-stop shop to get the mentoring you need to not only guide you into this career path, but support you all the way through to graduation day. So if you're a nursing student who's exploring the possibility, an ICU nurse actively pursuing CRNA, or a current nurse anesthesia student, you're in the right place. Tune in for inspiration and actionable takeaways that will help you from start to finish. Let's get started. Well, hello, welcome back to another episode of CRNA School Prep Academy podcast. I'm your host, Jenny Finnell, CRNA, and welcome back to today's show. Today, we are going to cover essentially what does a CRNA do as far as what's their practice actually like, and what does it mean to be a CRNA in an opt-out state. And I'm also going to compare and contrast the role of a CRNA in AA, which is Anesthesiologist Assistant, as well as an MD Anesthesiologist. And so that way, if you're kind of wondering, well, what the heck is the difference? What does a CRNA actually do compared to, say, being an AA or a physician? I'm going to enlighten you in this episode today. And then we're also going to briefly touch on being an opt-out state and what that actually means as far as a CRNA practice. And I'm excited to share this with you because I mean, speaking from being a CRNA for over 6 years, it took me that long in my career, you guys, because it just wasn't something that I actually paid attention to myself to even honestly figure that out. So, which is kind of sad, but I'm being truthful and I'm happy that I get to enlighten you because, and also being really upfront and honest with you guys, a lot of CRNA programs are really expecting their candidates to understand these differences prior to even coming in for their interview. Sometimes they may ask, well, what's the difference between an AA and a CRNA? And you'd have to enlighten them on what you know about that, or what does it mean to be an opt-out state? So a lot of these programs want you to understand this concept even prior to going into CRNA school. So I'm excited. Make sure you ping this as one of your favorites. So yeah, let's get into it. All right. So even if you're just starting to explore this career path, as I just mentioned, or whether you're getting ready to start your program, this is a topic that I really think that you should be well aware of and you should understand. So I think that this is a really great tool for you to kind of put in your arsenal to kind of just empower you and to kind of understand what being a CRNA is all about. So first and foremost, I kind of want to start this episode off with, essentially as a CRNA, you do work collectively as a team and you always act out of respect, right? I think a big part of being a professional in a career path, especially like a CRNA, is to be respectful as a team. So whether you're working with a attending anesthesiologist or an AA or another CRNA, it's always about respect at the end of the day and working collaboratively as a team. So that's really kind of the key component that I want to kind of start this whole episode off with. But back to kind of understanding, maybe tell me about the difference between a CRNA, an AA, and an MD, because some of these schools may actually ask this question in their interview just to kind of gauge your understanding. And also, I think what they're also looking for, you guys, too, is to kind of see if you're willing and able and understand the responsibility that you're getting ready to accept. Because you are accepting a very large responsibility as a CRNA, because we are independent practitioners. And so they want to make sure that you understand that. They want to make sure that you understand that, your scope of practice, while yes, it can vary from facility to facility, and also your own personal choosing for the most part, but they want to understand that you understand that you are taking on an independent practice role as an advanced practice nurse. So again, at the end of this episode, I'm going to kind of uncover what it means to be an opt-out state and various types of practices that CRNAs work in. But first and foremost, what types of settings do CRNAs practice? What kind of surgeries do they do? Is there anything that they can't do under their current scope of practice? And really the easiest, shortest answer for that is there's nothing that we can't do under our scope of practice. We really can provide surgeries for all different types of surgery, whether that's open heart, whether that's pediatrics, obstetrics, regional, so pain management. So dental clinics, ophthalmology clinics, fertility clinics, ketamine clinics. In fact, many CRNAs I know start their own pain clinics and run their own ketamine clinics. We even can do like med spas where we do a lot of different types of injections along that lines of work. So there's a lot of variation in practice, not just hospital work. There are a lot of things that you can do on the side, colonoscopy clinics, endoscopy clinics, those types of things. Now, I would say the vast majority of us probably all start in some type of hospital setting. I probably wouldn't advise you to go straight into working at a dental clinic or ophthalmology clinic right out of school, because you really could be kind of limiting your experience and your skill set by doing that. Now, it doesn't mean that if you choose to do that, that it's impossible for you to ever go out and get other experience. But the longer you only do that one experience, the harder it's going to be to kind of branch out. And so kind of that's the mindset I kind of took on when I was a new grad, was give it all. I want it all. And still to this day, I really try to seek out experiences in my own career path that will really challenge me in my knowledge and in my education and my skill set. Because for me, not only is that fun, yes, it's uncomfortable. Don't get me wrong. It is completely uncomfortable to essentially always force yourself to step out of your comfort zone. But that truly is where the gold is, you guys. That is where you grow. And I know you know this because you're embracing being a part of this podcast. You're embracing going into CRNA school. You're doing all the things to get there. And so it doesn't stop. Once you become a CRNA, if you keep that mindset that you had prior to even pursuing this career path, you're going to have such a rewarding and fulfilling career. You should always seek out new opportunities, in my humble opinion, because that really brings a lot of fulfillment and satisfaction in your career path. But yeah, I wanted to do open heart. That was kind of like what my calling was when I was in school, and I don't have an open heart background. I was a MICU nurse. In fact, early on in my nursing career, I was a nurse's aide, and they would float me to the open heart unit. And I had a couple really kind of traumatizing experiences as a nurse's aide. One of them, the patient, I was trying to get out of the chair. He was young, like in his 30s. He had just had open heart. And they always get him out of their chair so early. And I was like, oh my gosh, you have this giant chest wound. Oh my gosh. So but I was helping out of this chair, and he coded and fell on top of me. And I just remember screaming for help and trying to push him. He was heavy, off of me. And it was terrifying. It was like kind of left like an impression where I was like, I never want to do this as a nurse. Like, this is terrible that this happened. I had to watch this young man code, after all that. Right. So that happened. And another time I went there's this young girl, like my age, 20-something-year-old girl who I think had post-pregnancy cardiomyopathy, and they actually cracked her chest and did a sternal massage on her heart right in front of me. Like, it was her. I was just like, ugh, like, oh my gosh, they actually do that? You got to be kidding me. Again, I was a nurse's aide. I was very young. Pre-young Jenny was like, no, thank you. I want to stay way, way far away from that. But then, I worked in the MICU as a nurse's aide, worked there as a nurse, and it just wasn't, even though it was really challenging, it was a lot of really sick, a lot of comorbidity patients. For some odd reason, when I got to my cardiac training in school, I just loved it. I loved the pathophysiology. I thought it was just the coolest. It just made sense to me, right? It just was one of those concepts and those areas that I was like, I enjoyed learning about it. I enjoyed watching the surgery. I think the surgery is the coolest thing, to actually see a beating heart stop and start back up again. Seeing the cardiopulmonary bypass machine. Everything about it just fascinated me and kind of lit me up. So even though I didn't have the best experience in school as far as getting a lot of open heart numbers, I made it my mission when I was done with school to pursue cardiac as an anesthesia provider. And so I did that for about 4.5 years before we actually relocated to be closer to family. But that being said, I've also challenged myself to go back to doing just peds. I've challenged myself to go to a place where I get heavy regional experience, something that I had not had since school. And I had all the on-the-job training doing popliteals, interscaling, superclavs, and saphenous and adductor canals. Those are the primary blocks we did. But I did a lot of them. I did in 1 week, I would do 30 some blocks in 1 week. And so I got really proficient really quick. So I always challenge you that no matter what you do to seek out different opportunities as a CRNA, it really affords you more opportunities down the road when other positions pop up. So yeah, specialties like peds you can work in, adults, hearts, or kids, either one. EP lab is kind of in the realm of hearts where you're doing electrophysiology, where you're doing like AFib ablations, cardioversions, things like that. Obstetrics, so labor and delivery, putting in epidurals and doing spinals for C-sections. I did do that when I did 24-hour. I joined a call team when I joined the heart team, so I did 24-hour shifts. I did a lot of OB on those 24-hour shifts, mostly at night. And the way we did it is we did have an attending in-house, but we had two CRNAs, two 24-hour CRNAs. And so for the most part, unless we needed, the MD anesthesiologist to come sign off our chart, or maybe we had like a rupture AAA coming to the OR, or they had to come sign in a case that got started in the OR, they would come sign in. But for the most part, you really ran, especially OB, you really ran all the epidurals at night, and you would throw the paperwork under the door for the attending to sign off in the morning. So it was a very autonomous way to practice anesthesia in the middle of the night, essentially with you and your counterpart kind of running the main OR and OB. It was fun. It was hard. It was a lot of work. I'm not going to lie. I mean, that was, even when you had kind of a downtime, quote unquote, it'd be like an hour and you'd just be anticipating that beeper to go off. You're like, oh, what's coming next? And then, you would take turns. So like you would know if they got up for that pager, the next pager would be yours, and your mind would run like, what is it going to be? So I don't know. For me, it just wasn't my cup of tea. It really stressed me out. I just could never get myself to actually sleep. And then the way they situated it, which is kind of weird looking back, you had to share a room with whoever you were taking call with, and everyone seemed to snore. I'm like, why? Why does every single person, even the skinny petite women that I had to sleep with on call, would snore? And I'm like, I cannot sleep unless no one snore. And then I was always jealous that they could fall asleep. And I'm laying there like, I'm on this plastic pillow, sweating to death. Like, I can't sleep. So that was my experience doing 24 hours. Will I ever do it again? Maybe. I don't know. I never say no to anything. I'm always open to maybe some point in my life, I'll want to do it again. But for now, it just works to not do it. But neuro, so craniotomies, you could do sitting cranies, awake cranies, any kind of cranie, a bunch of like spines, backs. General anesthesia, obviously, just typical gallbladder, laparoscopic cases, anything that comes from the ICU. You can get some really sick patients needing like general bowel surgeries, like a toxic megacolon comes to mind, which are really, really sick patients. We've had like, not fasciitis, neck fash come to the OR multiple times. Ooh, those are really scary and disturbing cases. Ortho, any kind of orthopedic case. And again, a lot of times you're doing your own regional block for those cases, depending on the facility you work at. Like at the facility, I did a lot of regional. They typically would assign a CRNA to blocks, meaning you'd be the block CRNA that day. And so you'd run the block room. You wouldn't actually go to the OR. If you had a lineup of 9 shoulders, there would be a CRNA in that room doing the 9 shoulders, but you would do all the interscaling blocks prior to the patient going back to the OR. So that's how they organized it. And again, it was a very, very busy outpatient surgery center with a lot of regional blocks. And so there's just no way that to keep the pace of like a 5-minute, like in and out of a room block. When you're doing 20 some blocks, you essentially have a CRNA designated to just do the regional block. But yeah, so I've also known facilities who have like a CRNA block team. So they would actually go around room to room and do TAP blocks, for example, for various cases throughout the OR. So that's kind of been I also am getting ready to go work at a place where I know that some CRNAs typically do their own blocks before their case, which again, I haven't experienced that, but I just know that that's what I was told happens, is if you have a case where you can do a block, you're welcome to do the block, whether they do that in pre-op or back in the room, to be continued, ... I don't really know because I'm getting ready to start here soon. So we'll find out what that's like. anyways, endo. So you could spend a day doing, different types of endoscopy cases. There's a variety of types of endoscopy cases, but they typically have like endo suites that you can go to. They're either far away from the OR or they're close to the OR. I would say that in my experience, when I first started, they had an endoscopy suite that was a little bit further away. They actually moved it to be closer to the main OR for safety and convenience reasons. But again, just so you know, some places have like an endoscopy suite and it may or may not be considered kind of off-site. Then you have urology cases, where people doing kind of, prostate cases or kidney stones, those types of things. OBGYN, so any kind of obstetric kind of cases where maybe it would be like a ectopic pregnancy, some kind of uterine cancer, something like that. You could do any kind of OBGYN cases. Then you have thoracic, which or like lobectomies and any kind of cases to do with the lung. Then you have vascular cases, which are things like AV fistulas, abdominal aortic aneurysms. Any kind of vascular case, carotids, which carotids are a lot of work. Carotids are hard, but they're fun, but they're hard, but they're really fun. And then you have bariatrics. So like maybe a Roux-en-Y kind of case. And then of course you have offsite, which is like interventional radiology, MRI, those types of cases. So that's kind of a rundown of the typical. I don't think I missed anything, but I could have, because there's just so much that you can do at one facility that you work at. So literally all those cases I just ran off to you, every single one except for the regional, I got all that experience at one facility when I first started as a CRNA. I literally did every single one of those types of cases other than regional blocks. When I left and I moved to be closer to family, I actually sought out a position where I would get trained to do regional blocks. And so that's what I did. And that was a surgery center. Now, we didn't do open heart. We did some peds. I think the youngest peds we had there was like an 8-year-old. But for the most part, it was like older teenagers who would come to the surgery center. I wouldn't call it a pediatric by any means, but since I had some pediatric experience, it was kind of nice to like be more familiar with it versus some of the CRNAs I worked with had never done peds. I had all that experience at one hospital, and that was a level 1 trauma center that I worked at for 4.5 years. Got the regional experience. Again, I think I've spoken this before. It just wasn't my thing. I wasn't into the surgery center vibe. And so I moved on to pediatric anesthesia, which I love. It's hard. It's stressful. Don't get me wrong. I definitely I'm like, why am I doing this to myself? Making my life more stressful. But I just love the babies. The environment's really good to work in. It's been a really, really great place to work. Everyone's really happy there. The collaboration's great. The communication's great. I enjoy it. Okay. So I'm happy at this pediatric hospital. I'm getting ready to take a 1099 position at an adult hospital. They do hearts, although as a PRN, I don't anticipate doing open heart, maybe some EP lab and things like that. So we'll see how that goes. That's the place where supposedly the CRNAs who have regional experience under their belt can do their own regional blocks. But again, I haven't started yet. I don't know what that's going to look like. But the fact that I have that under my belt has allowed me to say, okay, well, I'm comfortable with it. I had adequate training, so I'd be very quick to pick it back up again. So that's what I'm trying to let you know. The more you kind of open your horizon as far as experience and skill set, the more you will have opportunities to go kind of advance your career in different ways that you may not have ever thought about. All right, so that's kind of like the scope of practice of a CRNA. Again, we practice all different types of anesthetics. We can practice. Now let's kind of go into like, what does it look like to be an opt-out state versus an opt-in state? And what does it look like for a CRNA practice? And, as far as, when I told you we didn't do any regional, my first practice, why was that? Versus where I'm going, they allow it. And before I get ahead of myself, let me slow down just a little bit. Where I originally practiced out of school was called an ACT model or a direction model, which all that essentially means is for billing, they have to have one MD anesthesiologist to 4 CRNAs. That's the ratio that CMS or Centers for Medicaid and Medicare for reimbursement, essentially. That's the ratio they had to comply by to get reimbursed. That facility, not only did we not do a lot of regional, like that just wasn't, I feel like they started trying to do more, but it wasn't what the surgeons were accustomed to. They just didn't promote it, unfortunately, where I worked. And, mostly the physician anesthesiologists were the ones who did the regional blocks there. Then when I moved to the surgery center, it was a supervision model. Now, a supervision model, again, it's a billing thing. It's just billing, okay? We still can practice the way we would always practice. But now, because of the billing, now you can have one MD anesthesiologist to over 4 CRNAs. And so typically we'd have 2 attendings there for the day and right around like 12 to 13 CRNAs. So again, maybe like 1 to 6, and at the end of the day, there would only like maybe more like noon, I should say, not the end of the day. Noon is the end of the day. Noon, a lot of times they would actually have the one attending leave pre-op, because for the most part, pre-op would be empty other than a few people. They would pass off to one of the CRNAs or the other attending who would mostly be covering PACU at that time. So then there'd only be one attending for like 10 CRNAs. And so they had some flexibility on how they staffed that, allowed the attendings to get out of work at a decent time all the time. And it just worked. It's just a different model. And, so that's the supervision model. So those are the 2 essentially. And then we have independent practice, which is all CRNAs, which is essentially you're utilizing, it could be like the surgeon, for example, who essentially you'd be working under that physician, which would be the surgeon, but you wouldn't have a anesthesiologist per se physician that you would be billing by. You would essentially be doing independent billing as an all CRNA practice. Now, I have never worked at a facility like that. I don't feel like it's super common to get facilities like that in my location, but they do exist. They're just not very common, but they do. They're out there. And so let's kind of get into the opt-out. What does it mean? If you're in an opt-out state, does it mean you have more independent practices? As far as answering that question, not necessarily. I mean, it really just depends, again, on the facility, on how they bill. Opting out is essentially a billing thing, meaning it kind of essentially frees the need to have a physician to bill under to get reimbursement through CMS. So again, it really depends on the facility on how they go about this. But we are making progress in the opt-out states. How many states are opting out of this CMS billing requirement kind of thing, which is 20 states currently are currently opt-out states. Maryland actually was the most recent one who just, Maryland did recently get prescriptive authority for both pre and post-operatively, which is a big deal because, and I can't really speak to this on a large scale, but I do know that like as advanced practice nurses, we are like one of the only, for the most part, that do not have prescriptive authority like an acute care NP would have, for example. So that is kind of, that's been a longstanding thing. They are making strides. And again, Maryland, we just got prescriptive authority in Maryland. So essentially it just allows us to prescribe preoperatively medications that we know the patient that we're going to be giving anyways, right? Without needing someone to sign off on it. So like when I did 24-hour shifts and I did epidurals overnight, I had someone put new epidural orders. I did all the orders, and even in the OR in my open heart, I would put in order sets all the time. The difference is the attending would have to then get notified or pinged versus via the electronic chart, and he'd have to put his finger on a piece of paper agreeing to the orders that I put in. So that's essentially the hang up versus me just being able to do it. So that's where it kind of frees you a little bit, is you don't necessarily need someone to sign off on anything. You have the authority to essentially sign your own orders. But yeah, so I kind of talked about the different models. ACT model, what you're here called. That's essentially direction model, which is just the ratio of 1 to 4, where, one thing I want to point out about the ACT model is this varies from practice to practice too, in the sense that emergence can be kind of negotiable as far as when does emergence actually happen. You can technically argue that emergence happens in the operating room or it happens in the recovery room. And so, for example, the first place I worked, it was an ACT model. And the attendings had to be there for induction. However, I was there for 4.5 years. A lot of them knew me very well, trusted me. And so there'd be times where they'd be hung up in their room. We'd be waiting. And so if I didn't feel like I needed someone else there, if I felt very comfortable with what I had going on, knowing it was safe, I would say, hey, are you okay if I just go ahead and get started? And 9 times out of 10, they would be like, yeah, sure. I'll be there to sign in. And so I would get started. Again, just no matter what kind of practice you practice in, it's your responsibility to make that judgment call. You have to know what's safe. You have to know when you have to anticipate what you need. If you're getting ready to put a 450-pound person to sleep who has severe OSA and you're like, I don't know if I'm going to be able to mask this guy. Yeah, no, you should get a second set of skilled hands at the bedside, regardless of what practice model you practice in. And so it really comes down to that at the end of the day, that practice model is a practice model, but you still always routinely provide safe care. And if you need a second set of skilled hands, whether that's a second CRNA, attending, an AA, whoever, get them at the bedside with you. Like that's, at the end of the day, that's always your responsibility. And don't just say, well, since I'm in a independent practice or a supervision model, even if I know this is kind of going to be a harder start, I'll just do it by myself. No, that's not the right way to go about anything. And there were so many times, you guys, where I worked at the surgery center and I phoned a friend, right? Because I'm like, I need you here. I know I need more skilled hands at the bedside for this induction because I anticipate X, Y, and Z. And that's always the key is when you ask for a second set of hands with you, if it's not the routine, know why you want it. So when you ask for it, you can have a good rationale to give them, like, I need you here because of X, Y, and Z. Then they know what they're walking into. So definitely make sure you're doing that. But yeah, so where I was getting to is even though that was an ACT model, a lot of times it was like they were at the room relatively shortly after we got started and they would sign in the case. All right. Now that being said, technically, this all goes back to billing and how they bill. And so, but I'm just letting you know that there's variations in how you will see practiced. The fact that they were there relatively shortly after, like sometimes even before I even pushed the propofol shortly after, you know what I mean? Where it would just be like, go ahead and get started, make sure obviously we'd always pre-oxygenate, but sometimes we're sitting there just like, can we push the propofol? So we'd start pushing the propofol really slowly and then we would mask and then get to the room and then they'd be there, that kind of thing. So you just have to kind of use your best judgment, but essentially where the direction model can kind of differ is in the wake up. And so like where I practiced before, routinely, they would not come to the bedside at wake up. Like that never happened unless you needed them. So if you needed the attending physician at the bedside for wake up, that would be your judgment call, right? Otherwise, they don't want to hear from you. It was just take them to PACU, make sure they're happy and comfortable and all's good, right? So that was kind of like the norm. That was the standard, the way they practiced. There were countless times where I would call them to the bedside because I was questioning whether or not they would fly, right? It's like, either like they're weak. I'm questioning whether they're gonna fly. And I want to make sure I had another set of skilled eyes laid on them. Or maybe you're having issues throughout the case and you want to ask questions. You ask questions all the time. If you're ever questioning something, you always should do your due diligence to get someone else at the bedside to ask these questions. Sure, there were cases where we did induction. I didn't see or talk to my attending the rest of the time. Took over a PACU, saw him for the next case, and we just kept going. There were some times where I literally didn't need any help or have any questions, and my whole day would be like that, where they would be there for the induction, and then I would see him for the next case for the induction, and the next case for the induction. And that would be all, for the most part, unless there was any kind of preoperative issues where they had to notify me of what's coming up down the pipeline. That would be the most communication I'd have with my attending all day. Then there'd be other days where I would talk to him in pre-op. We would do the induction. Then I'd call him back in the room a couple different times because blah, 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 blah is going on. Then I'd have issues in PACU where I'd say, hey, I need you over here in PACU. Or, there was just it varied based on the case and based on the patient, how much additional support was needed for that patient and the care. And sometimes I had to make sure I really did some good handoffs for PACU and to the attending because I anticipate them needing X, Y, and Z in PACU, and the attending should know that because he's the one doing a lot of the prescribing for discharge, right? So it just really depends. It just can vary patient by patient, shift by shift. Okay, so that's enough on that. But back to opt-out again. This all has to do with billing and essentially how CMS reimburses facilities for care, and the ratios have to be such. The attendings have to make sure they're there for induction and emergence in a direction model, and a supervision model. They have to be there. They don't have to be there for induction or emergence. So again, but they just have to be in the building and available. Then you have independent practice where they do not have to be in the building at all. In fact, you don't have to even have an attending anesthesiologist hired in the facility at all. Essentially, you're working under the physician's license of, say, like the surgeon or like the medical group itself. So that's essentially all opting out means is it's giving the facility more options as far as billing and reimbursement, and kind of taking away some of those red tape regulations. Now let's get into a little bit, but the practice is the same. So whether you're opt out or opt in, the practice is the same but it can differ from facility to facility. So just because you're an opt-out state does not mean you're going to have an autonomous CRNA practice. So let me just make that point one more time. Just because you have an opt-out state does not mean you will have an autonomous, like an all-independent CRNA practice. It can still vary from facility to facility. There are some very highly medical directed facilities in opt-out states, and vice versa. You can have an opt-out state or an opt-in state. And you can have a lot of autonomy within a facility in an opt-in state, okay? So whether you're opt-in or opt-out, it's still facility dependent. The opt-out, again, just gives facilities like gives them more flexibility on how they want to run their facility, right? But you can still essentially do it either or. So I want to make sure I make that clear as well. Because a lot of people think, well, I'm an opt-in state or an opt-out state. I'll get to practice independently. It doesn't always work like that. Okay, so let's go over the differences between AAs, CRNAs, and MD anesthesiologists. So essentially, you guys know, obviously, a CRNA, you're a nurse, okay? You are a nurse first and foremost. You get your bachelor's degree. Some CRNA programs will accept an ADN with a bachelor's in science. Not all schools, but that is out there. The vast majority do require a BSN degree to pursue CRNA. There are some people who say have like a background in who are like a respiratory therapist. They get their bachelor's and they go to an accelerated BSN program. They go to CRNA school. So you're like, well, I know an RT is a CRNA, but they still ultimately have to become a nurse. You can't skip the nursing part. And you also can't skip the ICU experience part. And just because you were an RT in the ICU does not mean that counts towards your nursing ICU time. You're going to have to get separate ICU time as an actual nurse. It's like that comes up. For some odd reason, that comes up every now and then. I'm like, it doesn't work like that. So anyways, just want to make sure I'm clarifying that. So yeah, ultimately a CRNA is a nurse. They have ICU experience. Now the ICU experience can vary to a pretty big degree. You can have people who barely have 1 year of experience, people who have 20 years of experience. And then you have people who come from like the ER, from the PICU, the NICU, the MICU, the SICU, the CTICU, the burn unit. I mean, oh my gosh, neuro, all kinds of stuff, like a melting pot of ICU experience, which I think is really cool and really empowering that we all have something unique to bring to the table. Like some of the PICU nurses, they are rock solid in their dosing of medications because they've always had to have a very good understanding of that coming from the PICU. They also see a wide range of pathophysiology between, say, a toddler who's 2 and a 16-year-old. I mean, so I think that's a strength if you ask me. But not all schools will accept PICU experience. I mean, I don't shoot the messenger, but that's just the way it is. Same thing with the NICU. That's a very, very subset of patients. And so it's a very narrow range. I think PICU, if I had to pick between NICU, PICU would probably give you a better range of experience for ICU experience. But that being said, I don't make the rules whether they take NICU, PICU, so don't yell at me about it. But just research this early and often so you know what your schools take. But yeah, so I think, again, having the ICU experience as a nurse, I think it's a really big part of our strength when you go into CRNA school, because you have good bedside manner, you have the communication skills, you have the team skills, you have all this sixth sense that you've developed when you know a patient's going to crash. So you have a lot to bring to the table, whether you know it or not. I know you're going to feel like a fish out of water when you start CRNA school, but I promise you, you have so much to bring to the table when you enter CRNA school because of your ICU experience. So don't underestimate that. And just because you've been out of school for a long time, don't fear that. Just because you haven't been out of school for a long time, you barely have ICU experience, don't fear that. Both of you can thrive in an equal way. You will have strengths, you will have weaknesses, you both will, and that's okay because you're going to build upon those strengths when you actually start your program. But that being said, an AA now doesn't have any medical background. So when you if I hear some people sometimes criticize people who barely have a year of ICU experience getting to CRNA school, but I'm like, well, you build up on those skills when you're in school. I mean, don't get me wrong. I think you should get good ICU experience. I think that's a really important foundation. But the same token, if you get into school with only 8 months of ICU experience, and by the time you start the program, you're going to have a year, I don't see what the big deal is for the most part, as long as your application and your interview have proven as such that you were rising to the occasion. And I notice like students, especially with very little ICU experience, they hit the ground running and they do okay. And is it kind of a hard adjustment? Sure. But same thing for the person who has 5 or 6 years of ICU experience. They might not like hit some of the skills running, like they might be more adapt to keep up with the pace. but they still have a lot to overcome with the knowledge part, right? Because they've been out of school longer, and now they're like, oh, chemistry. Oh my gosh, it's been like 5 years since I've done chemistry. Now I have to relearn it. Where the person who got into school sooner, it's like, oh, this academic stuff, I got it. This is a breeze, not really a breeze, but they can probably pick up on it quicker. So maybe that's more their strength, where their clinical is a little more weak, and vice versa. But that being said, like AAs don't have any medical background as far as they've never been a nurse's aide, they've never been an ICU nurse, they've never been really anything in the medical field. They just have to have a bachelor's in science, well, not a bachelor's in science, a bachelor's in anything. Literally, I think it was from the Purdue's website that said you can have, I wrote it down because just need a bachelor's in anything that excites your curiosity. And this was from Purdue's website. So AA school, no medical work requirement is needed. You take the MCAT or GRE, but they do have prereqs. So if you have a bachelor's in arts and crafts, I mean, I don't know, when they say that, I'm not sure what they mean, because then they still have science prereqs. So if you have a bachelor's in anything that creates your creativity, you're still going to have to then go take science prereqs, which include physics, math, essentially a lot of the prereqs that you would essentially get like in your ADN, but they also include physics and math, where some ADNs don't have physics or math as a requirement for that. They require a B- or better for all those science courses, whereas CRNA schools require a B or better. So that's something to kind of also think about as well. You might be thinking, oh, that's not fair. Well, I think it's a good thing. I think it's kind of a nice thing that we're a little bit harder, because I don't know. I mean, more power to us, right? Whoop, whoop. So that's just the difference between an A and a CRNA. Now, as far as practice goes, again, they essentially train the way we do. They go through clinicals. They essentially complete a master's degree, just similar to how we used to do it, as far as now we're a DNP program. But essentially, they went through very similar training. It was just obviously done through and under the anesthesiologist, the physician anesthesiologist. They're trained by anesthesiologists. They're trained by physicians, where we're trained by other CRNAs. Obviously, we're trained by physicians and clinicals too. Like, don't get me wrong, but most of our lectures and clinicals are all done. Clinicals, coursework is done by CRNAs, versus they're done through like a medical school kind of thing. But they essentially, practice-wise, they can do they're essentially doing everything that we do as a CRNA, meaning they do hearts, they do OB, they do regional, they do whatever. But that being said, in my time and my exposure to working with AAs, there are some facilities that kind of limit what they do, meaning some facilities don't let them go to OB. Some facilities don't let them do open heart. Some don't let them do peds, but some do. So it just depends on the facility as far as what their scope of practice is. But for the most part, they do actually function just the way a CRNA does, as far as doing all the different types of cases and skills. They can do A lines, they can do central lines, as long as they're proficient at it, just like a CRNA. But that also being said, they can only practice in 14 out of 15 states. So they're not fully recognized in all the states as anesthesia providers. So that's something to also think about. They also don't have any kind of prescriptive authority. And they're also essentially required to always work under the supervision or direction of an attending. Meaning that, you remember I talked about the direction model, supervision model. Well, AAs always work at a direction model. They always work a 1-to-4 ratio. They can never be higher than a 1-to-4 ratio, and hospitals can't get reimbursed to have AAs if the ratio ever changes from that. So like supervision models and obviously independent practice, you don't find AAs. So that's kind of unique to CRNAs. So that kind of explains that. And then the next thing to really cover is just MD, physician anesthesiologist. Now, obviously med school, right? We all know that. They go to med school, then they have 4 years of residency, 3 years of which is anesthesia based. Okay. So essentially, out of the 4 years, they have 3 years that essentially is covering anesthesia school. But again, we technically at the DNP portion is extending our program out a little bit, but you essentially practice anesthesia for also 3 years, essentially, getting your DNP. But out of that residency, they actually spend 4 to 6 months, depending on the program, in the ICU. So their ICU experience is again, only 4 to 6 months, where a lot of us have at least a year, if not more, of ICU experience. And again, the ICU experience, I think, is really vital. And I think we go into anesthesia school with having the most exposure to ICU. So I think that's a huge strength of a CRNA. But technically, if you look at like the time, for example, on AA, if you've done it, meaning if you literally get your bachelor's in science and don't have to do all those prereqs, I'm not sure how long that would take otherwise. But if you look at like a 4-year bachelor's plus a 2-year master's, you're looking at 6 years. And again, I don't know whether if you had your bachelor's, you had all those sciences done, that would speed the process. If you didn't, then obviously take those prereqs, it would slow it down. But you're looking at the fastest path to AA is 6 years. The fastest path to become an attending anesthesiologist is 12 years if you consider BS and science, med school. Well, so it's a bachelor's in science, med school, residency, 3 years of which is critical anesthesia, which is 12 years. So again, 12 years fast track to become an attending anesthesiologist. And then you have a CRNA, which is a BSN, 1 to 2 years of ICU, average is 3. So that equals 8 and 8 years. So 6, 8, and 12. Now, I would say the average path to CRNA is more like 10 years because a lot of people are not getting their BSN in 4 years. A lot of times it's whether they're getting their ADN plus their BSN. But again, I'm looking at like the fastest track, like literally if you got your BSN and then went to the ICU and spent, 3 years there. So that would be the fastest path to CRNA. And then you'd have 3 years of grad school. Okay. Did I do that right? 10 years, average 10 years. What did I just say? So, yeah. So anyways, so that's kind of the quickest pathway again for CRNA is average is 10 years. And the reason why that's different or kind of fluctuates is because the ICU experience can vary. So I hope that kind of clarifies the different pathways to become a CRNA and clarifies kind of how we practice as a CRNA and that the opting out and the whole, that's really just a billing thing. And whether you're in a direction model, supervision model, your practice is the same. The only difference is whether you have someone there at wake up, whether you don't, whether you have someone there for induction, whether you don't. But ultimately, at the end of the day, you get someone there for induction or wake up if you need them anyways. You will always have a resource person, whether that's, again, a fellow CRNA. You'll always use your judgment as a CRNA to know whether you need additional set of skilled hands is what I call it. So I hope you guys enjoyed this episode and I will see you next week. And thank you very much. I want to thank you personally for being loyal listeners and thank you so very much for tuning in. I appreciate you and I appreciate the reviews. I read them all. So thank you so very much and we'll see you next week. Hey, future CRNA, as always, I appreciate you and your loyalty. Thank you so very much for tuning in this week. I'd love to hear from you, so screenshot this episode and share it to your IG stories with your biggest takeaway. Don't forget to tag me at CRNA School Prep Academy so I can personally thank you. Be sure to head over to CRNASchoolPrepAcademy.com to check out our blog and gather free resources to help you along your CRNA journey. Stay strong, and I'll see you next week.